Now, I have been asked to present on the important presentations from the MASAC, which I've selected a few of them, and I will try to complete in the next 10 minutes or so. We are running a bit late, so as soon as my slides can start, I will start with the talk. Yeah, great. So next slide. So the first slide that I have selected is the first article that I chose was for CINV related presentation. So the first slide was the SPARE trial. SPARE trial basically looked at patient-reported outcomes in a patient where they tried to avoid dexamethasone. So the idea was that dexamethasone is to be used orally in a lot of patients on day 1 to day 4. Now, in India, I'm aware a lot of patients don't do that. A lot of us actually end up giving dexa only on day 1. But this was a study where they tried to look at if you could add a nitipetant, if you could add a palnosatron or olanzapine, and then tried to see whether dexamethasone was really needed for day 1 to day 4. Now, the primary endpoint, that was the CR rate in a delayed phase, was also then compared with secondary endpoints that included quality of life. Next slide. The first presentation of this was in the ESMO of 2021, where they showed that the primary endpoint was met. They showed that there was a 75% versus 79% non-inferior result in patients who received oral dexamethasone. So from the point of view of a CR rate, that is delay in the MSS, that point was met and you could avoid dexamethasone from day 1 to day 4. And this was the evaluation items for the PROs. Now, the way they looked at the PRO was looking at the initial on day 1 and day 2 to day 3, some fact questionnaire, and then they looked at the ESMO questionnaire at the end of 30 days. So that was the way they looked at the PROs. This was the initial rate. Like I said, there was no real difference between the results in terms of CR. Now, this paper in the MASCC looked at the patient-reported outcomes. What they found was that among the patients who have reported the different kinds of the PROs in the QOL, 281 patients, of which 274 were evaluable. The changes of score in global health status, nausea, vomiting were not significantly different. However, there was one thing which they noticed, that the appetite loss was higher in the day 1 only dexamethasone, and patients with nausea also had more amount of nausea in the arm 1. The severity of nausea was not different, but the amount of patients with nausea was different. Now, interestingly, they also noted that patients who had headache were more in the single day dexam. Now, there's no explanation given for this, but overall, the frequency of headache was significantly more. 43% reported mild headache, 2.2% reported severe headaches. Next slide. So the final conclusion of this study was that you could safely avoid dexamethasone. It will not impair the global health status in cisplatin-based chemotherapy, though there was a worsening of nausea and appetite loss. So further analysis would be needed to select suitable patients. In India, like I said, I don't know many people using dexamethasone. Personally, with the amount of infections around, I am a little skeptical, especially in those patients with diabetes and all those issues. So it lends us more hope to stop using dexa for orally for the next 4 days. Next slide. So the next paper is from Korea, where they looked at oral neutropeptide and oral neutropeptide for prevention of CINV. And also they looked at usefulness of olanzapine rescue. Next slide. Now, NEPA is something that is available in India, especially we do have a generic, and I think orally we are starting to use it in India. So this study looked at whether there was efficacy of NEPA for CINV prevention. They basically did a retrospective cohort study. If patient had grade 2 or higher CINV, they also added olanzapine. And olanzapine could go up to 5 mg in non-responders. Again, a dose which is important. Many times the Western dose goes up to 10 mg. So here it's 2.5 mg twice a day. And only in non-responders, you would go up on the dose. Next slide. What they found is that NEPA was effective in reducing the CINV. And they found that of 157 patients, mostly biliary tract cancers, bladder tract cancers, and breast cancers, a high emetogenic regimen, which is cisplatin AUC4, the overall CINV incidence was 70%, and incidence of grade 2 or higher was 35%. Those patients who got olanzapine rescue. 43 were treated with olanzapine rescue without any dose modifications. 30% in 30 patients, almost 70% improved to grade 1. So next slide. Again, this confirmed that NEPA is a pretty useful addition to the treatment for CINV. It is comparably effective. It also showed the usefulness of olanzapine rescue. The next paper looked at investigating patterns of opioid use and again association with patient-reported outcomes. This was a study from Canada. Next slide. When they looked at the patients, they went ahead with a retrospective analysis and tried to see how many patients actually got opioid, and they also tried to look at the amount of opioid usage. So these patients used the Edmonton Symptom Assessment Score. So the paper that I was describing was on morphine opioid use, and they looked at low-dose morphine. So as I was saying, they categorized the patients by dosage used by daily oral morphine equivalents. They looked at low dose, moderate dose, and high dosage. And the primary outcome was the pain score. Next slide. Now, what they found is that the patients who were requiring higher doses of morphine, so what they found was that out of 6,400 patients, only 35% patients actually had. Right. So basically, what they found was that despite it being in a place like Canada, they felt that the usage of morphine was inadequate, especially for those needing high amount of morphine. That's something we see as well, that in India, I guess the amount of morphine usage is lesser than what it can be. This paper, I will just skip. Next slide. They looked at factors affecting peripheral neuropathy over time and wanted to see if cognitive factors could impact this neuropathy. The end result of this study did not show any major effect of the cognitive response, but that again was a thing that they said we need to study in detail. So they found that pre to post treatment, they had an increase in the neuropathy, and they did have some association with cognitive features, but there was no real intervention that could be made in this study at least. The next paper tried to look at a proactive web-based self-management education and coaching for management of treatment toxicities. Next slide. This was from Australia, and where they found that patients, those who were being given standard education versus those patients who were given a specific training along with 5 sessions of nurse-led telephone coaching. Very interesting study because we keep talking of how to use this in our own practice in India. Next slide. Now, interestingly, what they found is that a lot of patients actually could not do the full 5 sessions of phone training. And though 87% of patients initially took the first step of education, the attrition was much higher in the intervention group. The usage of this phone management of the algorithm was very low. Only 30% intervention patients completed all 5 calls. So that kind of tells you that it is not as simple as it sounds. And though the number of patients are only age 62, still a lot of these patients, despite being university educated, did not actually complete the adherence to the I can manage that software that they were using. So again, as a way to use in India, we do try to have a slightly different usage pattern in India. Now the internet usage as well as the telephone penetrance is much higher in India. Also in India, a lot of patients come from rural areas to the urban areas to take treatment. So this might be something that can be explored in India as well to see if we can do the toxicity management. Next slide. So the last paper that was actually in this, which I found interesting, was the use of yoga. So this was the paper where they looked at yoga versus a behavioral placebo in looking at cancer-related fatigue. This was a randomized trial. Now, interestingly, it was done in the US. So next slide. So maybe being the US, they have used a very copyrighted method of yoga for looking at the cancer-related fatigue. This was called yokas. Don't know what exactly it includes. The abstract did not talk on that. They also used against that a rigorous behavioral placebo known as a survivorship health education program. Next slide. Now, between the two of them, they wanted to see if there's a benefit in patients who had cancer-related fatigue. They used only cancer survivors, 2 to 60 months after treatment with no distant metastasis. 5 CRF domains were used, and they also used a fatigue symptom inventory to assess the overall CRF. Now, what they found is that among 502 survivors, the patients who were given yoga had a significantly greater improvement in overall general and mental outcomes than compared to conventional intervention at post intervention and at 3 months, though there was no difference at 6 months. Now, whether this was because by 6 months the number of patients themselves had improved post treatment was not known in this. So, next slide. So the final conclusion was that you could use yoga as one of the intervention for treating overall general and mental health in cancer survivors, and this could be sustained 3 months later. So again, something that we should look into. Most of us allopaths do not like things like yoga, but I think this is a place this is a therapy that has a place, especially in patients post treatment. So this would be my last study. I thank the organizers for giving me this opportunity, and I apologize for the frequent technical dropouts.